pounds, and I thought that was humongous. I'll probably never see anything like this again for the rest of my life.
I thought he was assigned to the surgical service.
Probably the greatest risk of losing control of the tumor during the removal process is just falling off the table before we had controlled the blood supply to the tumor.
Okay, lift up there. I think we got plenty of firepower here, guys. That looks like a giant vessel there. I would clip that. Right flank. All right, let's not lose sight of her kidney. That's the next dangerous thing on the list. Now, that's a giant vessel there. Don't go low. Don't be too impatient here. You see this vessel? Yeah. This is the umbilicus, and this is a perforator through the abdominal wall to the tumor around the umbilicus, and we're going to try to take that apart.
I think the scariest thing for surgeons about the neurofibroma patient tumor, they're not normal vessels, and they don't respond to cauterization, and they don't have muscularity in their walls.
Tie, please. David, help me. Wire cutter, please, Karen. Good. You got a big enough clamp to hold that together?
Tie it? Yeah.
That's good. Whoa, stop. That's pretty good. Huge vessel here and there. Hemostat ready, please. Go slowly. I still think we have a chance to roll her to the right if we dissect this up some more for you. That's a big improvement. But we need to bring her whole body this way. You tell us when we can move again.
I'm ready, but I can't do anything else.
So heavy.
Early on in my career, this guy came in with a huge, fungating, really awful head and neck tumor. The tumor was disgusting. The maggots made it even more so. So our first act was to think, oh my God, we've got to get rid of these maggots. It looked as though he had suddenly had this overwhelming infection. Here's this guy walking around for years with this tumor, and probably for at least months with this maggot infestation. And he dies the day we take away the maggots. So I started thinking, how did that help? What did that do for him?
Knife, please. I've opened the chest safely, and now I want to put a retractor in here if my staff will give me one. Okay, that's one.
Look like barnacles.
So Dr. Backer now is putting stitches in to anchor that new valved conduit. Okay, put a clamp on that. I mean, it's possible that this will last her the rest of her life. This graft. We wanted to, anyway.
Neurofibromatosis. There are no other therapies that she could have been helped by. She needed to have this tumor off. It's as simple as that.
There was what we call a benign ovarian tumor, an abnormal growth of the ovaries.
Very rapidly and became very ill, and by the time he got care, he was already in very advanced sepsis.
Transformation to malignant cells. Some of the vessels were extraordinary there, and it certainly led us to think that this was as big as it got.
Suck. You gotta suck, David. Suck on it. It's too wet.
When we had taken off the abdominal portion of the tumor and started to work on the back, it appeared to me then that the bleeding was really the most difficult to deal with there.
What the hell? Now what's bleeding? Hemostat. Right angle. Scissor. Sponge. Come on, quick.
Forceps.
Right angle. Watch out. We got a big bleeding here. Tie. So. That was over. That was big and over.
There was sort of white fibrous covering, those little mottled blue areas that you could see in it, presumably due to the fluid. As you felt it, you could tell that it was fluid filled. It was what we call fluctuant, kind of like maybe a beanbag chair. Spindly little arms and legs.
It wasn't until after the fact that we found out that it was possibly the radiation that triggered the growth of the tumor itself.
So much blood that even her brain was affected, which would be the last organ to give up the blood.
You got it?
Well, look at that. What's that, do you think?
Clothing?
Fabric, clothing.
A lot of contamination in here. It looks like the gunshot has brought in fabric or clothing or part of the automobile interior if it really did go through the door. And right now we're taking all this tissue out. This is debridement of the tissue that's actually dead around the surface.
So she's not left with a big bolus of non-viable or non-living soft tissue that would give her a problem with infection.
A blunt rate, please.
The risk to this lady's life is significant, and she may not live for more than a few days, but mainly because of the injury to her intra-abdominal contents, including her rectum and her anus.
The maggots kept her alive.
What I will be doing after I make the incision is dissecting upwards on the fascia of the chest until I come to the pectoralis major muscle. And then I will dissect beneath that muscle, basically about as far as I can go. I'll actually have to cut some of the fibers off of rib and the lateral part, inferior part of the sternum or the breastbone. Start with the scalp and the forehead, and then we'll go down to the chin, followed by the tapering of the lower jaw, and lastly the nose. Looking at the two, I see I'm not totally symmetrical, so I need to take out just a little bit more over here.
We've just made our skin incision in this patient's chest, and now we have the sternal saw that we will use to split the sternum or the breastbone right down the middle, as is done in any open heart surgery.
Cerebral injuries, commonly fractures of the occipital bone.
The stomach is a bag-like enlargement of the alimentary canal. Main section lies between the esophagus and the duodenum. It looks like a curved sac with the cavity facing toward the right. This we call the small curvature. It has a variety of functions, not all related to digestion.
Into the chest, through the mediastinum, right above the heart, but it went through some big vessels in his esophagus, out the mediastinum, through the diaphragm, over on this side, into the liver, through the liver. You're freed up now. The dissection's complete. We can now take the old liver out. Okay, the liver can go. So if I say good. Can we get the new liver up, please? I'd like to have a look at it. There's a big hole left behind now where the liver was. Okay, the scissors, please. And that's the colour a liver should be. There's the portal vein. Vena cava looks fine. It's nice and smooth. It's good size. She's had a gallbladder out in the past.
I see.
Good. So we've got a nice short ischemia time. This liver's only been removed a couple of hours ago. So we now need to slide this forward on that swab. Jane, we need you to put your hand over the top and draw the liver down there. Be very careful. One of the risks is pulling one of the bypass tubes out. The patient would be in big trouble if that happened. We're about 5 minutes off reperfusion, Marc. Now, Marc will want to give all sorts of goodies to make her as stable as we can when we reconnect the liver. That's the most critical time, really. The portal vein now, and once that's sutured together, we can then put the blood back through the liver. This is a nice size match for her, isn't it? It's nice and small. It's about the size her liver would have been before it got diseased, I guess. Okay, we're ready to unclamp now. Moment of truth. Okay, so top clamp first. Scissors, please. Are you happy with the Marc? This is the crucial moment now.
Yeah, that's about right.
Okay, top clamp's open. And away. I'll give you the portal next. Say when?
Yep.
Portal vein. If you watch the liver, Janusz, you should see it change colour and swell.
Changing colour already.
Changing colour already. Here we are. See that?
It's already pinky.
It's already pink. That's right. Joint looks watertight. Bottom caver. Clamp is off. Okay. That's all the clamps off.
Good.
She's pretty stable, actually, isn't she, Marc?
Oh, yeah.
She's pretty tough, I think, actually, and doesn't seem to be upsetting it too much so far. She's not out of the woods yet.
So what is the immediate risk for a patient after the operation?
Well, the initial problems are of primary non-function, of the graft just not working from the beginning. And then the first few days there's problems like the arterial supply not working. And then later on we get problems with rejection and infections and the like.
So already you can say that the new liver is functioning?
Yeah, you can tell straight away if the new liver's working by some of the early function tests, the body temperature, the correction of the clotting disorders, things like that. Good. So, top caver, bottom caver, portal vein, hepatic artery, bile duct. Pretty dry, really, for a liver. And now we just put Mrs. Morton back together again. Well done, Mrs. Morton.
Painful rash on the groin, which is a little odd. Usually cellulitis, which is inflammation of the skin, usually isn't painful. I and your physician looked at it and looked at this whole general story.
He's a cardiologist.
He's in cardiogenic shock.
Gluteal cordis, cardiac concussion.
lung artery and main artery being connected in an incorrect way. We will need surgery to switch the vessels back into a correct position, a so-called anatomically correct position. To stabilize the baby, you usually create a hole within the heart. This is excellent. This is excellent. I'd ask you to decrease the depth. And now I need the rashkin. Yeah. This is the only one I have.
Okay, wait. Oh, that's
Yeah,
why.
no pressure in.
Yeah, no pressure. Thanks.
Okay, this is the Rashkin catheter, which was developed by Dr. Rashkin in 1966 or something like this. This is the catheter itself, and this is the volume I used most of the time. It's about 15, it's almost 2 centimeters by 2 centimeters, and it needs to be pretty firm here. And this is what you put in the left atrium into the left filling chamber, and then you pull it back with all the force you have. Once in a while, this whole balloon can rupture and can fall off. Then you do need the surgeon right away. This procedure revolutionized the treatment for these children because before that was introduced in the 60s, 90% of them died within 1 month of age. And this procedure truly was a major step in helping blue babies. I'm about to inflate the balloon now.
You can see that. You can see that on this thing. Okay.
Am I okay? Mitral valve is okay?
Yes, you're not near the mitral valve.
Okay. What's the sap doing now? Okay. Okay, actually I'm inflating to 3 cc's. Okay, deflating. Okay, we'll go ahead and do this again. Oh, you need to have to do it a couple of times. I didn't have a lot of resistance. I need a little bit more force. Okay, you recording? Okay, quiet please, quiet please. Okay.
62 cents.
Okay, okay, it's better. Okay, so I'm going up to about 3.5. I feel pretty safe. So we have pretty good flow. Nevertheless, I do 2 or 3 more to make sure the septum doesn't try to fuse again. You have to be persistent. That's a pretty nice one here. We still have to stabilize the baby with ventilation, most likely with nitric oxide medication, and we should let the baby recover for about 5 days, 5 to 7 days, and then we plan to send the baby to surgery next week. Have a 3D image, how it's structured, what the shape is, and what the course and direction of the PDAs. So with this needle, I plan to puncture the vessels and then introduce this wire, and over the wire introduce a so-called sheath, a small plastic tube. The vessels in children are small, so you have to go diligently. So I'm using a small angiocath, a small plastic hub to exchange the wire, and I can feel that the position is correct.
Start using a catheter next week. There's no bleeding. Everything looks good.
Scalpel, please. Make a little skin nick. This is really the only scar that will remain, is this small skin nick with a blade. I have a 5 French sheath in. And over this wire, the sheath, which is a shorter tube, will be inserted, and that allows me to change catheters. Floating this balloon up into the left lung artery, Again, this measurement of the left ventricle demonstrates that her heart is working harder than it's supposed to be. This is the aorta, the main artery. The PDA is this jet here, and it fills the lung artery, which is this structure here. And it's supposed to be the same size compared to the aorta. You can easily see that this is much larger than it's supposed to be. Again, this is the main artery, and this jet here signifies the ductus arteriosus from here to there. Once you start pushing the coil out of the catheter tip, you are committed to deploying it. You're committed to putting it into the patient. You have to be careful. If you push too much into the lung artery, then it might embolize. It might move into the lung artery, and you have to retrieve it again. If you leave too much, it might dangle in the main artery. The actual angiogram, the picture, will help me determine what to do. And I spent probably 1/3 of the whole procedure is measuring the PDA and thinking about what coil to choose for the particular child. Yeah, it's a little bit, yeah, it's pretty short, but it's not well shown in this projection, because it doesn't run in this direction, but it runs this way. So it, yeah, so it's probably here. I'd like to take another injection, please. So this PDA is somewhat unusual in terms of the direction. It is relatively small and short. So I have to find some landmarks. I'm looking at the left upper corner. That will be my reference. So the tip of the PDA is probably there. Now advancing the coil slowly towards the catheter. And so this is the length of the coil here. A small portion of the coil. Before I do this, I'll come back a hair because I'm too far into the pulmonary artery, and I will remove this catheter, disconnect the coil, and then pull back and see where it stops. That is the lip of the PDA. Yeah, I can feel that resistance here. That's when your heart rate goes up, and you hope it all stays where it's supposed to stay, and it seems to do that. So the kinetic energy is released now. The coil is reorienting itself a little bit, but it seems to be in good position. So we'll take an angiogram in about 10 minutes. Now the angiogram will hopefully demonstrate complete closure, and if that's the case, we'll be done. Inject, and that's it, off. There's a tiny little spray which will close. That is not a problem. It doesn't obstruct the flow here in the main artery, so it's well placed. It closes it sufficiently. And again, this is only 10 minutes after placement, and over the next couple of months, it will be plugged completely, and then the inner lining of the aorta will cover this. So we're done. Success. Success, yes. Yes.
Problem with the fetus. He was not developing the way that you normally would develop. And we're going to have a spot.
External soft tissue, which is usually minor injuries. You worry about intra-abdominal injuries, anything related to small bowel, to gastrointestinal tract, and the urinary tract.
There's the X-ray machine from above, so I can see what I'm doing to the bones. You'll see it doesn't take much to break the bone once you've weakened it with the... And then I use a thing that looks like a chisel to crack the bone. And it's only the bone cut is done through like a 1/4-inch incision.
So we've separated the face from the skull base. Now the forehead is still missing. Let's put that back and then do the extractions. Splint will be wired in around teeth and also cemented in for molars. That gives us a good anchorage point for the lower part of the face. So we just align this, and it's put on quite simply. It's about a thumb breadth from the scalp. It's about 3 or 4 centimeters above the top of the ear. And then for her, particularly in this case, because she has so many soft spots where the pins are going to go, I just feel with my hand to make sure I've got some good bone underneath there, and that feels pretty good.
The heart is much larger than normal, and that's a result of the extra blood flow flowing through the lungs that he has from the hole in his heart. So we'll get going here. Bypass, this is the aortic cannula, which will carry blood to the body, and then the 2 venous cannulas, which will take blood away from the body. And after we go on the heart-lung machine, you'll see the heart will empty out of blood, as no blood is flowing through it or through the lungs. So Nick, are you ready?
Ready.
Okay, here we go. We'll give you the SVC first. Flow down on the pump, Nick.
Pumps down.
Clamps on. We go in antegrade. Okay, we now got a clamp to separate the circulation. And we'll stop the heart from beating now with a solution containing some potassium. Towel clamp that for me so it won't slip. The pressure feels good. Nice arrest, Nick. Solution fills up the coronary arteries, these little vessels that feed the heart, and then they stop the heart from beating. It's just a monster. And you only see the tip of the iceberg until you look up underneath the valve. Not so unusual.
See the valve light pink?
That's a humdinger of a hole, and it goes all the way down here. That is way up there. See that? That's a huge defect. And see how it extends all the way to the aortic valve. All right, what we have now is the heart open through the right atrium. Here's a hole in the septum of the heart that we'll have to fix, and then this is a valve of the heart. By pulling the valve back, you can see there's a hole from one of the muscle chambers into the other. And we now need to put our series of stitches around it so we can separate the two. Because blood isn't passing through the heart right now, we have to make sure to give the heart a little oxygen every once in a while during the operation. That's what we'll do now.